That was a great introduction. Thank you so much. Our next speaker is Dr. Kennecke, who is a medical oncologist here in Vancouver at the BCCA. And Dr. Kennecke is going to tell us about an overview of current and planned clinical trials for NETs patients.
All right. Good afternoon, everyone. It's my first CNETs. I've been to ENETs and the other meetings, but I am impressed. I don't know what I'm impressed by more, the fact that there's so many people here, or the fact that you're all still here on a sunny Friday afternoon. But I'm a medical oncologist, just like Daniel, but I actually hang out in a different place around the elephant, not with Daniel. And I work here in Vancouver, and what I was asked to talk about is to give a more of a general perspective of where we're going with clinical trials, and getting a little more specific exactly what kind of trials are we going to be doing. Daniel set the stage very nicely in terms of telling us, defining a lot of these terms. So what I'm going to do actually is describe a recent consensus meeting that was held. A number of us in the room were actually at the meeting in Boston in November of 2009. It's a clinical trial planning meeting of the NCI Neuroendocrine Task Force to look at what types of trials we should be focusing on and what questions we should answer. Then we'll look at some current trials in carcinoid tumors, and then we'll have some fun and just review some current trial ideas. So what is needed for neuroendocrine trials? I mean, certainly it is very important that we all speak the same language in terms of tumor staging, disease classification, trial eligibility. These are all critical elements to make sure that we are all on the same page. Collaboration, I mean, I don't have to emphasize that. This is a very multidisciplinary tumor site, and you'll notice all the specialists, and I did put medical oncologists last, because up until recently, medical oncologists haven't had a big role in this disease site, but I do think that's changing as we have more options. So here are some of the consensus points regarding tumor classifications. So it was agreed upon that if we develop new agents in this disease site, we should probably separate patients with carcinoid tumors from patients with pancreatic neuroendocrine tumors. It was also agreed that while we should include carcinoids from all the different sites, we should make sure that we should stratify by site of origin. So we can't be, this is a small disease site, we can't be too exclusive, but we want to be inclusive, but we need to make sure that we account for the behavior of the different tumors by stratifying for them. It was agreed that aggressive neuroendocrine histologies should be evaluated independently from the more indolent ones. Molecular classification, we've heard a lot about today, and obviously that's very important. What about defining stage? Now, this is where, I could have some tomatoes thrown at me by the Europeans particularly, because there's a lot of controversy about what the right way is to classify neuroendocrine tumors. It was agreed, relatively, that the AJCC classifications should be adopted as a reference for NET clinical trials. Now, keeping in mind that this was mainly a North American audience, I've just updated briefly you on the new classifications according to AJCC of GI neuroendocrine tumors. These have come in effect as of January 2010, and we at BCCA did decide to accept them. We're going to go with, classifying according to what the majority of our North American colleagues are probably doing. So the relevant facts are that GI carcinoids are separate, and they are subsites, small bowel, large bowel, appendix unknown. And the other principle is that high-grade neuroendocrine tumors and goblet cell carcinomas of the right colon are excluded from the term of neuroendocrine tumors. Pancreatic neuroendocrine tumors are classified with the pancreas, but of course different histology. Here's a comment. We heard a lot about tumor grade and classifications in Chi-67. Here is how AJCC7 is looking at the data. They feel that mitotic count and Chi-67 are the two relevant factors to consider when looking at tumor grade. And we had a lot of discussion about tumor heterogeneity. Thomas was telling us about, the salami looks different depending on where you cut it. Well, the rule with AJCC is that you look for the area of highest proliferation in the tumor for mitotic count, as well as the highest staining for Ki-67 when you're trying to figure out what the counts are and where this tumor should be classified. So mitotic count is less than 2, 2 to 20, greater than 20. Ki-67 is less than or equal to 2, 3 to 20, or greater than 20. Now, we've all seen many different cut points. We've done a lot of research in other tumor sites with Ki-67. For example, breast cancer, separating the good from the bad, that cut point, our group did a lot of research on that. It's about 13 or 14. So, who knows where exactly it is, but, I don't think this number that they chose was arbitrary, but it is certainly a broad range. So, what about local and regional disease? How do we look at that? Well, for adjuvant, I think it certainly is agreed upon that adjuvant therapy, so therapy given after curative resection with no evidence of disease, is currently not indicated in completely resected nets. And that's relevant because a lot of times surgeons send us patients who've had a tumor resected, nothing left, and they, patients say, well, now what, doc? So the development of tumor registries, however, is encouraged so we can better understand risk factors and prognostic markers of those who relapse versus those who don't. Carcinoid syndrome is a huge area of clinical need that we need to answer questions. Randomized studies need to be done to look at and are encouraged to look at novel areas. Anyone with uncontrolled carcinoid syndrome can attest to that. There is an initiative underway to develop carcinoid-specific quality of life type of questionnaires, so specific for that population. And hepatic-directed therapy, again, we've heard a lot about that, but a recommendation was made that we do need to evaluate these multiple different modalities that are out there right now. And randomized phase 2 trials are the way of the choice of answering some of these questions. So peptide receptor radiotherapy, this is less of an area of research in North America than it is in Europe, as we, for regulatory and other reasons, are not able to synthesize these, but we do need to answer questions in terms of head-to-head trials in this area as well. And then in the area of advanced neuroendocrine tumors, there are some Daniel just emphasized the importance of including only patients with progression in trials, as well as there's later on in that slide you'll see listed the relevance of different alkylating agents that we maybe should look at in pancreatic cancer. So overall, the message is that progress has been made in neuroendocrine trials. And I, although I don't stand at the same spot on the elephant that where Daniel is, I do agree with him that we've seen some huge advances in this field. In the last 3 years, we have 2 major phase 3 trials reported. One of them we just heard about with Sutent, and I'm going to update you on 5 that are currently ongoing. So that is a major increase in research done in this tumor site. But we do need better design. We need, and better design will automatically lead to faster accrual and more relevant results. And I think really what it boils down to, what the objectives of the current clinical trials that we need to do is to identify new agents and to evaluate the agents that we currently use. So here are we've heard a lot about the results of reported clinical trials. Here are the current pending trials. The first one is, in the first column, the arms of the trials are presented, and in the second column is whether or not what phase it's at, and the third is what the endpoint is. So the first trial is a SWOG study actually, and looks at the value of bevacizumab compared to interferon in patients with carcinoids. So all these trials are in carcinoid. I'm just choosing the carcinoids now. Basically that will answer for us, hopefully definitively, whether or not bevacizumab has any role in this disease site. The next trial is the RADIANT trial, which Dan already showed some slides on. It's to look at in a head-to-head way, what is the benefit of an mTOR inhibitor, everolimus, RAD001, in this disease site. The good news is the first trial is going to be accrued in a year, and we'll have answers in probably 2 to 3 years. The second trial, all the patients have already been accrued, and we should have an answer as to whether or not this agent is effective in this disease site within the next year or so. So, you know, if that happens, we can see, you know, a couple of major new therapeutics come available for carcinoid within the next 2 to 3 years if the trials are positive. The next trial is looking at the value of lanreotide versus placebo, and that is that is more of a pharmaceutical you know, question, whether this is a valuable agent in this disease site. The next trial is a head-to-head looking at pasireotide, that's SOM230, versus octreotide LAR. So we've all heard about SOM230. It targets different receptors more selectively than octreotide LAR. So what is the clinical value of this in patients with uncontrolled carcinoid syndrome? We will get an answer to that. And the last one is, we've heard a lot about the PROMID study looking at the value of somatostatin therapy in patients with asymptomatic disease. And one of the issues, although it was a fantastic trial and it kind of definitively answered that question, is that it only was restricted to patients with mid-gut carcinoids. But what about the patients with large bowel or foregut or pancreatic carcinoids or pancreatic neuroendocrine tumors? Well, these are included. So the trial is looking at lanreotide versus placebo in non-functioning PNETs in carcinoids. So that's really phase 3. Phase 2 is a little bit further in the future, so we have more work to do to decide whether or not these drugs are worth examining. We've already heard about, from this table here, we've already heard about the first 3 trials. They've been deemed sufficiently effective to take them to the phase 3 setting. And then there's a combination that's being looked at, everolimus versus pasireotide, that's the 4th trial. Further down, I'm not telling you about, you know, phase 1 trials, and this list is by no means exhaustive, but I'd like to draw your attention just to the targets that we're exploring in this tumor site: VEGF receptor, insulin growth factor receptor, very appealing targets. Again, the VEGF receptor with a different pharmaceutical, as well as histone deacetylase inhibitor. So all of these are new therapeutics that are currently under development. So what about some other trials? What are some other trials that we can think of? And essentially that's kind of the follow-up of this clinical trials planning meeting, that we're kind of sitting down and going, okay, what trials do we need to do now to answer these questions? And we've identified the criteria, the structure. One of the ideas is to look at the combination. So we heard a little bit earlier about blocking more than one spot in the cascade. So not only blocking mTOR, but also blocking angiogenesis. So what is the value of combining those 2 agents? This could be evaluated in a head-to-head phase 2 randomized trial. What about, now we've heard about very encouraging and definitive results, really, of Sutent in PNET tumors. However, what about carcinoid? We do not have any information in a phase 3 setting that Sutent will work or does work or is useful at all in the setting of patients with carcinoid tumors. So this is an obvious area to look at next, and there may be a trial that can be developed in that setting. Certainly, carcinoid syndrome, there haven't been any further trials in planning that I know of, although there's so many out there. I'm sure there's some in development. Unresectable pancreatic neuroendocrine tumors, the idea here is to look at some new therapeutics for this patient population and look at the standard versus some new chemotherapeutics which are actually potentially better and certainly, for the most part, better tolerated. And so this is another potential randomized phase 2 trial idea. Radioisotope therapy certainly is being widely used, and you've already heard a bit about it, and you're going to hear more this weekend. It's certainly a lot of rationale for why this is promising a therapy to evaluate. We've got about 300 patient experiences described in neuroendocrine tumors with one of those two radioisotopes, with response rates of about 30%. So looking at that in a head-to-head fashion would be an important next step. So in conclusion, I think that we really have seen a dramatic increase in neuroendocrine trials, phase 2 and phase 3s. I do think that neuroendocrine tumors are on the map. They have garnered broad attention at all levels, basic research and in clinical trial groups. We do need to take a closer look at the hepatic-directed therapies that are under widespread use. I do think that it would be hard to argue that a major need is that new therapeutics are needed. And finally, let's not forget about the early stage disease in the setting where we potentially can administer adjuvant therapy for patients with completely resected disease. So those are kind of my perspectives on the trials that we potentially can do, and hopefully at least some of them will materialize. Thanks very much.